Welcome to Sleepy Nursing, the podcast where we break down nursing school stress into something you can actually fall asleep to. I'm Nick, for some of you, Mr. Forney, and I teach nursing students how to think critically, survive the chaos, and still get some rest. If you're watching this preparing for a test, remember, you can do this. Take your time and don't second guess yourself. You're smarter than you give yourself credit for. This is video 2 on cardiac disorders. For a quick recap, in the last episode, we covered some basic anatomy and got a little bit into congestive heart failure. So in congestive heart failure, CHF, we see congestion, pressure, and poor perfusion. We have a few different kinds of congestive heart failure. There's right-sided and left-sided, and there's systolic and diastolic. Remember the ejection fraction we discussed? Normal is 55 to 70. In patients with heart failure, it can be down as low as 15 to 20%, and those patients are typically very symptomatic. In systolic heart failure, this means the heart can't squeeze well. The heart muscle is weak and stretched out, so it can't push out enough blood. Remember that analogy we had before of it as a worn-out sponge. If you squeeze it, not much water comes out. This can also be called heart failure with reduced ejection fraction. You might see that in a chart as HFrEF, heart failure with reduced ejection fraction. Diastolic heart failure means the heart can't relax well. In this case, the heart muscle is stiff, so it doesn't fill with enough blood between beats. This one is like a sponge that's too hard to soak up water. Even if you squeeze it, it never holds much. This one may be called heart failure with preserved ejection fraction. HFpEF in the chart, heart failure with preserved ejection fraction. Both types can cause similar symptoms. Think if your blood's not getting through your body, your symptoms are going to be pretty similar. You'll be tired, you may have shortness of breath, and you may have swelling. But both of these types have different causes and different treatments. Common causes of heart failure can include coronary artery disease, where our arteries, our blood basically gets clogged up with cholesterol and fats, and they deposit in the walls of the artery, which hardens them and can actually shrink them down too. Hypertension, myocardial infarction, that's a fancy way to say heart attack, and valve disease. How do we diagnose congestive heart failure? Our main tools, our assessment is first. Everyone has to be seen by somebody first, and that's where nurses shine. So we may observe these symptoms, the tiredness, especially the lung sounds, the crackles. They'll sound kind of juicy when you auscultate. You'll also observe physiologic symptoms, swelling, edema, ascites, that jugular vein distension we've talked about. When we bring our diagnosis up, the doctor will likely order a chest x-ray, EKG to see the electrical activity within the heart, BNP, and echocardiogram. Echocardiogram tends to be the gold standard in my experience for heart failure. And we'll do those pretty commonly, and they'll give us the ejection fraction as well. So depending on what you're doing, my background in oncology, we would use these before giving cardiotoxic drugs so we could have a baseline to make sure we weren't damaging the heart too much more than we should have. How do we treat congestive heart failure? We have medications we use. We'll use diuretics. Why diuretics? Diuretics are going to pull fluid off of the body and out through our urine and put less pressure and workload on the heart. We can use beta blockers. Beta blockers help the heart beat slower and with less force, so it doesn't have to work as hard. They can also help control blood pressure. If you think about them, they give the heart a chance to rest and recover. They're kind of blocking it having to work too hard. ACE inhibitors relax blood vessels so blood flows more easily. This can lower blood pressure and make it easier for the heart to pump. Easy way to remember this, ACE inhibitors open up the pipes so the heart doesn't have to push as hard. And then digoxin. Digoxin helps the heart squeeze stronger. This means more blood gets pumped out with each beat. So if you think about this one, it gives the heart a little boost in strength. There are a number of lifestyle changes we'll recommend. Sodium restriction, remember water follows the sodium. It wants to follow the solute. And so if we limit sodium, we can cut down on some of that water being held like it's not supposed to be. We'll also often give these patients fluid limits. If they have severe heart failure, they are people who are being very mindful of every little bit of fluid. We're not just willy-nilly flushing more than we have to. I've noticed some nursing students want to round up their flushes, where a peripheral IV, you really want to flush with 3 mLs, they'll round up to 5 and say, no big deal. With these patients, that can add up and that can get to be a big deal. We can also want to do weight tracking. So the most reliable way to gauge fluid balance is daily weights, remember. So we want to track these patients at the same time every day, and we'll give them fluid limits as well. So they shouldn't just be drinking and drinking. In the hospital setting, we'll very commonly put this on the wall or on the door going into the room so that all the staff can be on the same page. So that when they call, hey, can you fill my pitcher again? The nurse aide, while they mean well, won't be working against that patient's interests. There are some advanced interventions. There's something called an LVAD, left ventricular assistive device. I strongly encourage, there are some very cool videos on YouTube detailing that device. I love sharing that with students. It shows the heart, and it also shows very clearly how that pump goes around and helps give the left ventricle an extra boost. And they can use an intra-aortic balloon pump, which goes in and inflates and deflates with each beat to help relieve pressure and optimize pumping. What do you do as a nurse working with these patients? Well, we monitor I's and O's, so intake and output, very closely. We do those daily weights we talked about. We're assessing for signs of fluid overload. Our assessment includes the respiratory system, how our patient's breathing is working. And we reinforce patient teaching. So when they're in the hospital, it's kind of easy for us to be in their business all the time, but we want them to be able to maintain some of these therapeutic changes when they go home. So the diet, the low sodium diet, it's hard for them to get salt out of their diet sometimes. And there's alternatives, things like Mrs. Dash, though you have to consider some of the concerns with those alternatives to salt. Medications and symptoms. What symptoms should they report when they go home? We also need to think about when we need to escalate this. So if they're calling in, or you notice in the hospital they have a sudden weight gain, this can be as much as 2 to 3 pounds in a day or 5 pounds in a week. And this would suggest the body's holding on to too much fluid. Increased shortness of breath. This goes back to our ABCs if we think about our priorities. If our breathing is not working like we expect, that's an issue. This is something we need to bring up a notch. And if you think about it, what are we probably going to do for that patient? Diuretics. Pull some of that fluid off so that our lungs can work like they're supposed to. We need to look out for new or worsening swelling, especially in the legs, feet, or abdomen. Coughing more. These patients may commonly have a wet cough, and they may give a little pink or frothy mucus with that. That's due to the left side of the heart backing up and putting pressure on those pulmonary vessels, which then leaks out into the lungs because those pulmonary vessels back up and they're congested, and that will leak out and come out in the form of a pink tinged cough. Chest pain or tightness is an alarming symptom. Faster or irregular heartbeat, dizziness or fainting, and changes in mental status like confusion or feeling sleepy. These are times we need to escalate our care up a notch. If they're in the hospital, these could be a reasonable time to call a rounding nurse, or if they have an acute mental status change, it's appropriate to call the rapid response at that point. Make sure you follow your facility's policies with that. But an easy thing to remember anytime, if your patient cannot breathe well, cannot think clearly, or is suddenly swelling or gaining weight, it's time to reach out to the provider and move things up a notch. All right, cardiac dysrhythmias. A normal rhythm, normal sinus rhythm, is our only fully normal rhythm, and that is a heart rate between 60 and 100 When you look at the EKG, you have a P wave representing the SA node sending out a signal across the atria, a QRS representing the ventricular depolarization, that's the squeeze, and a T wave representing it's all going back to baseline. If we have those things aren't working like they're supposed to, we have an abnormal rhythm, which is a dysrhythmia or an arrhythmia. Now, this is a big topic and it warrants its own video. I'm going to briefly cover on some very common things that I've noticed that seem like they've been helpful to some of my students here, but this does deserve its own video. Common causes of dysrhythmias include electrolyte imbalances, drug use, myocardial infarction, and even stress. Drug use, we think about hard, bad drugs, but even something like caffeine can cause us to throw some premature ventricular contractions throughout our morning. I probably had some this morning after my coffee. When we get into rhythms and dysrhythmias, I want to start with sinus rhythms. So as I discussed before, a sinus rhythm starts at the SA node, the sinoatrial node. It has a beat that starts in that right upper part of the atrium, the right atrium, and it sends it down. From that beat, everything south of that beat works like it's supposed to. Our atria does its little kick to squeeze blood down into the ventricles. Our ventricle squeezes like it's supposed to, and the rhythm looks like it ought to. Normal sinus rhythm, like I said, has all those elements, and it's between 60 and 100 beats per minute. Sinus tachycardia and sinus bradycardia are pretty easy as well. So the only thing differentiating them from normal sinus rhythm is the rate. So we know what tachycardia is. In this case, when we're talking about sinus tachycardia, we're talking about a heart rate greater than 100. Now, this can be a normal finding. If someone, for instance, I like to go run for exercise, when I'm running, my heart rate will go up in the 150s, 160s, hopefully not in the 170s. I feel some kind of way when it does, but it's pretty normal, right? So if my patient just showed up to the doctor's office and had just hiked up 5 flights of stairs because the elevator was broken and their heart rate is 150, and when you check on the monitor it looks like sinus tachycardia, are you going to be alarmed? Not necessarily, no. I would expect that if they just exerted themselves. Now, contrary to that, if you have a patient who has been resting, maybe they're bedbound or they just woke up, and their heart rate is high like that, I'm a little concerned. The flip side of that, sinus bradycardia, is any sinus rhythm below 60 that's still regular. And here, again, athletes and people who do a lot of exercise may have a resting heart rate below 60. My little smart ring says my heart rate is in the 40s when I sleep, and I don't have any symptoms, and that seems to be fine. But if you have someone who's not an athlete, that can be a bigger concern. Now, there is a sinus dysrhythmia where the heart rate, the beat is still coming from the SA node, but it's not regular. But the rest of the beat looks the same. The P, the QRS, and the T are all present, so the rest of the heart is working like it's supposed to. So think sinus rhythm is coming from the sinoatrial node. Now moving into atrial dysrhythmias. These are rhythms where the beat is coming from the atria. It's no longer effectively coming from the sinoatrial node. It's coming from either a point or several points of irritation across the atria. In atrial fibrillation, if you think of fibrillation, I want you to imagine fibrillation like jiggly jello. In atrial fibrillation, it's the atria are not squeezing effectively. They're irritated and they're just jiggly jelloing around. Now, the ventricles are still working like they're supposed to. If you observe this rhythm on an EKG, you'll see a squiggly baseline and you won't notice any P waves. You'll actually see little F waves for the fibrillation waves, is what we call them. The ventricles are still contracting like they're supposed to, but we miss that atrial kick. So in these patients, you will see cardiac output decreased a little bit, typically 5 to 10%. Depending on what they're doing and their overall status, they could be symptomatic or they could very likely be asymptomatic. A lot of people live with atrial fibrillation. When you think about atrial fibrillation, I really want you to think about blood clots. These patients are at an increased risk for blood clots and all of the complications associated with that. As that atria is fibrillating, as it's doing its jiggly jello, that blood is sitting stagnant right in the middle of it. It's not moving through like it's supposed to. And when blood stays in one spot, it starts to clot up. Now, if that happens in your heart, as in the case of atrial fibrillation, it can throw clots all over the body. So these patients will very commonly be put on blood thinners. A flutter is similar to AFib in that the beat is coming from the atria, but an A flutter, it's actually kind of bouncing around. And some of these beats, there's a few points of irritation, and this electrical impulse is moving basically in a circle around the atria. And every few beats, one gets through and triggers the ventricles to work. This looks very characteristic. It looks regular, and it looks like a sawtooth pattern. You can also have wandering atrial pacemaker, which is having 3 or more different looking beats. They look kind of like the P waves basically, representing different points of irritation around the atria where that signal is now starting. And then multifocal atrial tachycardia, the only difference between multifocal atrial tachycardia and wandering atrial pacemaker is the speed. They both have 3 or more points of irritation in the atria that are triggering these electrical impulses. So each of those rhythms will look a little bit different, but one's faster, one's slower. That's the only thing. Now down to our ventricular dysrhythmias. These get very dangerous. They suggest the ventricle is not working like it's supposed to. And the ventricle is the part of the heart that actually does the bulk of the work. The left ventricle, you think, squeezes blood out to your whole body. So if the left ventricle is not working like it's supposed to, all of your body's not going to get perfused like it's supposed to. We discussed previously some of the organs that are extra sensitive to that. Your kidneys, your brain, your lungs. So in the big ventricular dysrhythmias that you'll think about are VTach and VFib. There are a few others as well, but ventricular tachycardia and any of these ventricular rhythms you'll think about. One thing I want you to pay attention to when you're looking at EKGs, and again, this will be its own video, they are typically wide and grotesque looking compared to a normal sinus rhythm or a normal not ventricular beat. It has the normal QRS and it comes back and it's thin, 0.12 or less. The ventricular beats are wide and they look crazy when you look at them on an EKG. So you can really see them from across the nurse's station when you look at the tele monitor. In ventricular tachycardia, it's beating very fast. We can still have some cardiac output. Your patient may still be conscious, but they may lose consciousness as well. It's beating too fast to really pump blood effectively. It's not slowing down enough to let it refill and do what it's supposed to, but they can still have enough cardiac output to sustain consciousness. In ventricular fibrillation, remember that fibrillation jiggly jello that we talked about with AFib? Now this is happening with our ventricles. Now where AFib, the ventricles were still working right, in VFib, the big part of the heart that squeezes blood out to the whole body is fibrillating like jiggly jello and not pushing blood out right. This is a very dangerous situation and needs prompt intervention because we're not going to have meaningful cardiac output at this point. I don't expect this patient to be conscious under any circumstance. They're having a medical emergency. Now, VTach itself is a medical emergency. That's a reasonable time. If they have a pulse, call a rapid response, get the doctor down there ASAP. If they lose the pulse, go ahead and call your code blue and get the whole thing going. VTach very commonly devolves into VFib, and VFib, there's not a lot of living that patient gets to do unless we can get ahead of it quickly. So that's a brief overview of cardiac dysrhythmias, and again, this deserves its own video. Moving forward, I want to cover infective endocarditis and valvular disease. So what is endocarditis? Remember, the endocardium is that inner lining of the heart, and anytime we see itis, we think inflammation. A lot of the time that's from infection. In the case of endocarditis, this is an infection of the inner lining of the heart, especially the heart valves. It happens when germs, usually bacteria, get into the bloodstream and travel to the heart. What causes it? Bacteria can enter the blood through a number of things. Dental work is a relatively common cause of endocarditis. Someone with poor oral hygiene, maybe not brushing their teeth very often, or maybe brushing too hard while they have gum disease. IV drug use. I've seen endocarditis. I remember very clearly a 20-year-old patient, a young woman, with endocarditis after IV drug use. And it's just a shame to see like that, but it can affect anybody. Central lines or catheters. I want you to think about central lines and catheters both as basically being like super highways for bacteria to get into our body. A central line, if you remember, is an IV line that often, like a PICC line, will come in through the arm, a port will come in through the chest. There's a few different places they can come in, but the central line part is they let out in your central vasculature. So that's a tube now where there wasn't a tube before, that a germ, if this device isn't properly maintained, a pathogen can crawl up and end up in the very deepest part of your body, where it can then be sent out all over your body. And one of the first places it'll set up shop is your endocardium, set on one of those valves a lot of the time. And catheters are also a common place for pathogens to enter the body. Heart surgery or valve replacement can be a cause of endocarditis. Those kind of make sense intuitively. And having a damaged or artificial heart valve both make infection more likely. What symptoms are you going to see? Fever or chills. As with any infection, this is a very central infection, so this can be a pretty strong fever. Fatigue, feeling very tired. So not only are they battling an infection, but now they have an infection and inflammation in their heart, likely on their heart valves, causing them to not close like they're supposed to. So you might have a double whammy of both infection and poor valve function, poor cardiac function through this. You may see muscle or joint pain, shortness of breath, swelling in the legs, feet, or belly. These sound very familiar to our congestive heart failure, right? You could also see small red or purple spots in the skin inside the mouth or under fingernails. You could have chest pain. It's not as common. And maybe feeling like you have the flu, but it doesn't go away. The easy thing to remember, endocarditis. Think endo, inside, card, heart, itis, inflammation, infection. So in this case, it's an infection in the heart. If a patient with a heart problem gets a fever, feels extra tired, or shows weird skin changes, report it. Valve disorders are often caused by endocarditis. They can also come from rheumatic fever. The assessment and treatment, we're going to give IV antibiotics to get over the infection. They may require surgical repair to either repair or replace those faulty heart valves. And those patients are going to get anticoagulants so we don't end up throwing clots all over the body. Moving on, we're going to discuss pericarditis and cardiac tamponade. Pericarditis. What part was the pericardium? Peri, remember, around, like a perimeter. Card, heart. Itis, inflammation. So it's that sac around the heart is inflamed, potentially infected in this case, and irritated. Think of it like a sandwich bag around the heart. When it gets inflamed, it can hurt and squeeze the heart. What can cause pericarditis? A viral infection. This is most common for pericarditis. We can see this definitely after a heart attack or heart surgery. So in a heart attack, a part of the heart has lost blood flow and it will be inflamed and bothered, and that can include the pericardium and cause some of these issues. Autoimmune disorders like lupus can cause this, injury to the chest, and certain cancers or kidney failure. What's pericarditis going to look like? Sharp chest pain. Now this can be positional sharp chest pain. It's often worse when lying down or breathing in. Think about where the heart is. When we're sitting upright, it's kind of suspended, and it can actually be a little more comfortable for the patients if they lean forward a little bit. That takes some of the pressure off of the pericardium that's so uncomfortable. But when they lay down flat, everything's kind of pushing against it and giving it less space, and it will be less comfortable. So expect with pericarditis, those patients will feel better sitting up and maybe even leaning forward a little bit. We're likely to see fever again. Think about infection. Shortness of breath, feeling tired. Now, where this gets really spicy is when we get into cardiac tamponade. This is a medical emergency that can happen if too much fluid builds up in the pericardium. So in pericarditis, we may have extra effluent or fluid building up inside that pericardium. Now in cardiac tamponade, this is so much fluid that's built up in there that it's pushing against the heart, and now the heart can't actually beat against it. If you imagine we need some space to breathe, and we can still breathe if our chest is underwater, but if you have something heavier, like you go into a curing vat of concrete, all that weight pushing on you and then taking up the space, and it's shoving, and at a point you won't be able to expand your lungs anymore. This is kind of what's happening with the heart. It's in a bag that's filling with water, and there's only so much space for it to go, so it can't pump effectively anymore. Imagine the heart is in a balloon filled with water. If the balloon fills too much, the heart will get squished. What's this going to look like? Low blood pressure, fast heart rate, sounds like shock, trouble breathing, weak or faint pulses, jugular vein distension because it's backing up, it's not pumping effectively, and feeling faint or confused. We're losing our perfusion to the brain. Our blood is backing up because our heart can't beat right into the lungs, causing some of that breathing issue, and might even sound kind of coarse and wet in their lungs. And the JVD demonstrating that as well. Often pericarditis can be treated with rest and medicine, whereas cardiac tamponade typically needs emergency treatment to drain the fluid. Next, we're going to cardiomyopathy. There are a few types of cardiomyopathies: dilated, hypertrophic, and restrictive. Now, these can all cause heart failure too, so this is all living in a similar cardiac dysfunction world. So cardiomyopathy itself means the heart muscle is not working normally. It may become stretched, thick, or stiff, and any of these can make it harder to pump blood. There's three main types. Dilated cardiomyopathy. In dilated cardiomyopathy, the heart is backed up too much and the muscles have gotten stretched out and now they're weak. The chambers, especially the left ventricle, gets bigger and it can't squeeze as well. The walls get thinner, the space in there gets bigger, and it can't squeeze like we want it to. So think dilated, maybe distended. The heart is too big and floppy in this case. This is the most common type. It can be caused by heart attacks, alcohol, or infections. The next kind is hypertrophic cardiomyopathy. In this case, the heart muscle itself has become too thick. It's not getting thicker and more effective, it's getting thicker and working worse. The thick walls make it harder for the heart to fill with blood and can block blood flow. Think hypertrophic means heavy walls. The muscle is bulky and stiff. This one may be genetic, and it can cause sudden death, especially in young athletes. And then restrictive cardiomyopathy. In this one, the muscles become stiff but not as thick. The heart can't stretch and fill with blood like it should. Think restrictive is rigid. The heart's tight and can't relax. It's not very common. This one's rare. It may be caused by scar tissue. What could cause scar tissue? Think myocardial infarction leaves major scar tissue in the heart. This could come from radiation for cancer, like a lung cancer if they want to radiate. Unfortunately, they can't just radiate the spot. They kind of have to take a number of directions, and that can go in and damage the heart on its way to radiate whatever other tumor they're trying to radiate, and certain diseases. So symptoms of all of these types of cardiomyopathy: tiredness, shortness of breath, swelling, irregular heartbeat, dizziness or fainting. That all sounds very familiar, right? If the heart doesn't work, tiredness is probably top of the list. Now, in severe cases, these patients may need heart transplants, and we should be teaching their families CPR in case they need it in an emergency. So, to conclude, cardiac disorders are common and dangerous, but they're treatable. Your role as a nurse is vital in catching early signs, educating patients, and preventing crises. I want you all to review your anatomy. Make sure you feel very comfortable on your anatomy. If I understand the anatomy, I can understand all the dysfunctions much better, particularly in the heart. If you think about it, that left-sided versus right-sided heart failure, if the right side of the heart backs up, what's behind that? I know my anatomy, so I know that's my systemic circulation, and that's where I'm going to see my ascites and edema. If my left side backs up, what's behind that? I know it's my lungs. So my lungs are going to have dysfunction. I'm going to notice breathing issues, crackles, shortness of breath, that kind of stuff. So anyways, thank you all for joining me. Please leave comments if this is helpful and if you have any suggestions. Like I said before, I'm hoping to make every video a little better, and I hope to bring you something of value that can help you get through some of these complicated topics. If you're here, I believe you can be successful. Tuning into this shows that you're committed to nursing school, and you owe it to yourself to make it through successfully. And I believe in you. Have a nice night.